Good morning, everybody. Now we will discuss oral submucous fibrosis. Oral submucous fibrosis is a chronic disease affecting oral mucosa, the pharynx, upper two-thirds of the esophagus. It has been found that aricanet is the etiology behind this fibrosis. Aricanet derived product commonly used by several hundred millions of individuals in different parts of Asia. There is a dose dependence between aricanet, chewing gum, and the development of this mucosal disorder. Aricanet contains alkaloid choline. It is seen to be the primary etiological factor of the fibrosis. Ursulene has the capacity to modulate matrix metalloproteinase, lysyl oxidase, and collagenase, all these affecting the metabolism of collagen, which lead to the increase of the fibrosis in this disorder. There is a genetic predisposition, polymorphism of gene encoding tumor necrosis factor alpha has been reported to promote the development of this disorder. Fibroblasts are stimulated by tumor necrosis factor alpha, leading to development of this disorder. Now, what is the oral complication associated with this disorder? Lips, buccal mucosa, retromolar area, soft palate mucosa, widely affected. It can be seen in different parts in the world: India, Pakistan, Bangladesh, Sri Lanka, and immigrants from these regions. Now, what is the clinical findings associated with disorder? The first sign are erythematous lesion, sometimes associated with BTK, pigmentation, and vessels, followed by pallar mucosa, which is white marbling. And the most prominent clinical characteristic is the presence of fibrotic band located beneath an atrophic epithelium. Increased fibrosis lead to interfere with speech, tongue mobility, decreased ability to open the mouth, which is the most important complaint of the patients. Atrophic epithelium may be lead the patient to unable to eat hot. Now, how we can diagnose this disorder? The diagnosis of oral submucous fibrosis is based on a clinical characteristic and on patient reporting having the habit of chewing beta liquid. There is an international consensus to reach where at least one of the following characteristics should be present so we can reach the diagnosis of submucous fibrosis: the presence of palpable fibrous band, mucosal texture feel rough, leathery, a branching of mucosa together with histological. Now, what is the management of this disorder? Products derived from aricanet are carcinogenic, regardless using with tobacco or without tobacco. Treatment of oral submucous fibrosis should be focused on cessation of the chewing habit, which is the aricanet. If this is successfully implanted, early lesions have good prognosis and they may be regress. However, there are several treatment strategies has been tried, such as topical and systemic steroid, supplementation of vitamins and nutrients, and repeated dilatation using physical devices, and finally surgery. None of these treatments reach a general acceptance for everybody. However, there is a malignant transformation of the oral submucous fibrosis between 7 to 13% and an incidence of occurrence over a 10-year at approximately 8%. Now we will talk about the immunopathological diseases of the red and white lesions. We will talk about the lichenoid reaction. Lichenoid reaction represents a family of lesions with different etiologies with a common clinical and histological appearance. Neither clinical nor histopathological feature can discriminate between different lichenoid reaction, but it may be used to distinguish lichenoid reaction from other pathological conditions of the oral mucosa. Oral lichenoid reaction include the following disorder: oral lichen planus, lichenoid contact reactions, lichenoid drug eruption, lichenoid reaction of a graft versus host disease. These lesions represent delay hypersensitivity reaction to a constituent derived from dental material. We will start with oral lichen planus. The etiology of oral lichen planus is not well known, but it has become evident that immune system has a primary role in the development of these diseases. It is supported by histological characteristic of subepithelial band formed, infiltrated, dominated by T lymphocyte and macrophages, and the degeneration of basal cell layer known as liquefaction degeneration. These features can be expressed by mediated arm of immune system being involved in the pathogenesis of the oral lichen planus. T lymphocyte cytotoxicity directed against antigen expressed by the basal cell layer. It is complicated to identify a single etiological factor behind oral lichen planus. Other factors, such as stress, may be important. It is not unusual to have a patient reported and exposed to a negative social event months before the onset of the oral lichen planus. Altogether, this makes the etiology behind the oral lichen planus is a multifactorial process. So, during recent years, it has been found an association between oral lichen planus and hepatitis C patient. It has been described in population from Japan's Mediterranean countries. This association has not been observed in other countries such as North European, United States, and Arab countries. However, there is a research nowadays find this an association. A prevalence has been reported, and it is vary from 0.5 to 2.2%. Among referred patients, women has a higher prevalence than the men. The mean age at the time of diagnosis is approximately 55 years of old. Clinical finding: oral lichen planus may contain both red and white element, which can be part of the following clinical types. There is a reticular type, papular type, plaque-like, bullous, erythematous, ulcerative. Oral lichen planus confined to the gingiva may be entirely erythematous with no reticular or papular element, and this type of lesion should be confirmed by biopsy. The explanation of different clinical manifestation of oral lichen planus is related to its magnitude of subepithelial inflammation. So, a mild degree of inflammation provokes the epithelium to produce hyperkeratosis, for example, whereas more intense inflammation may lead to partial or complete deterioration of the epithelium, which is bullous type or ulcerative type of oral lichen planus. Typically, reticular, papular, and plaque-like are asymptomatic, although some patients may experience a feeling of roughness. The bullous form is very unusual but may appear as a bullous surrounded by a reticular network, which is the Wakeham striation. Erythematous, which is the atrophic, characterized by a homogeneous red area. When this type of oral lichen planus is present in the buccal mucosa or in the palate, stria are frequently seen in the periphery of the lesion. Ulcerative lesions are the most disabling form of oral lichen planus. Clinically, there is a fibrin-coated ulcer surrounded by an you can see this picture. The first one is a reticular type with Wickham striation network of white striae. The second one is the papillary type. Third is the plaque type, which is resembling to the leukoplakia. Erythematous. This is the ulcerative type in the inferior border of inferior surface of the tongue. And the last one, which is the discoid lupus erythematosus. I put the picture here so we can further discuss it later on to compare between. Clinical manifestation. Continuous lesion may be seen in 15% of patients with oral lichen planus. The classic appearance of the lesion consists of pruritic erythematous, flat-topped. The predilection site are the trunk, flexor surface of the arm, and the leg. The most frequent extraoral mucosal site involved is the genital mucosa. 20% of women presenting with oral lichen planus have a genital involvement. Symptoms include burning pain, vaginal discharge. Following intense scratching of the lesion, trauma may be aggravated by disease, which is referred to as a Kopner phenomenon. This phenomenon may also be of relevance for the oral lichen planus, which is a continuously exposure to physical trauma during mastication and brushing. Lichenoid contact reaction to dental material, which are most often detected on buccal mucosa and lateral border of the tongue. Oral lichen planus, on the other hand, this is the continuous lichen planus. Oral lichenoid drug eruption have the same clinical and histopathological characteristic of oral lichen planus. The patient history may give some indication as the patient using a drug, but oral lichen planus may not start when the drug was first introduced. Withdrawal of the drug are the most reliable way to diagnose lichenoid drug eruption, but it may not be possible to carry out sometimes. Oral graft-versus-host disease has the same clinical appearance of oral lichen planus, but the lesion is usually more generalized. The lichenoid reactions are frequently seen simultaneously with other characteristics such as xerostomia, presence of localized skin involvement, and liver dysfunction. So there is a system. Erythematous oral lichen planus of the gingiva showed similar clinical presentation as a mucous membrane pemphigoid. In pemphigoid, the lesion in epithelium is easily detached from the connective tissue by probe or gentle force, Nikolsky sign. A biopsy for routine histology and direct immunofluorescence are required for an accurate differential diagnosis between oral lichen planus and pemphigoid lesions. Discoid lupus erythematosus show white radiated striae, sometimes resembling those of oral lichen planus. The striae in discoid are typically more prominent with a more marked hyperkeratinization, and the striae may be terminated abruptly against a sharp demarcation. Histological criteria for lupus erythematosus has been oral and genital lichen planus. There is no relation between the degree of severity in oral and genital sites. Genital sites has been reported in male, but the association of oral lichen planus is not as frequent as for women. Esophageal lichen planus has been described to occur with oral lichen planus in some patients, the main complaint belongs to dysphagia. So patient complaining of this dysphagia, this may give hint that patient have oral lichen planus extended to esophagus. Now, the diagnosis. Papular or reticular component have to be present in order to establish a correct clinical diagnosis. These pathognomic components may exist together with plaque-like erythematous bullous or ulcerative lesion. However, patients with gingival erythematous lesion may be difficult to have this stria or papules. A biopsy is usually required for an accurate diagnosis. So it is very important to indicate biopsy whenever there is a gingival lesion. The biopsy must be taken, or preferable to be taken, from the gingival pocket to avoid Now, what is the management of patients with oral lichen planus? Since the etiology behind the oral lichen planus is unknown, basic conditions for development of preventive measures are not found, are lacking. All current treatment strategies are aimed to reduce or eliminate the symptom. Several topical medication suggested to have a benefit, including steroids, retinoid, ultraviolet phototherapy. Among these topical steroids, the widely used and accepted as a primary treatment of choice, very potent steroid, clobetasol, propionate, in favor of intermediate steroid such as triamcinolone acetonide, which is the quinolone in oral base. Cyclosporine may be considered as a second choice of treatment, although the efficacy has been questioned. Tacrolimus, immunosuppressant, should only be used by experts when symptomatic oral lichen planus lesions are reluctant to the topical steroid. That's mean when the patient unable to have a benefit from the topical steroid immunosuppressant. Now we should talk about the topical steroids. Topical steroids in general are preferred to be used as a mouthwash or a gel. These formula are often easier for the patient to administer than the best. A reasonable approach to have the drug 2 to 3 times a day during 3 weeks, followed by a tapering during the following 9 weeks until a maintenance dose of 2 to 3 times a week is reached. When potent topical steroids are used, a fungal infection may emerge, and there is a parallel treatment with antifungal medication may be necessary. Since half of oral lichen planus patients showed candidal infection, antifungal medication may be used before the treatment of steroid. However, there is no randomized controlled trial to use different formula, different strategy, different classes of topical applied steroid has been compared. Oral lichen planus is considered to be a pre-malignant disorder or potentially malignant disorder. The risk is low and presumably does not exceed an incidence of 0.2% per year. However, it is an pre-malignant or Now we will talk about a drug-induced lichenoid reaction. As the clinical and histopathological appearance is a delayed hypersensitivity reaction, drugs or their metabolite with the capacity to act as a inhibitors trigger, which is a type of antigen, a lichenoid reaction may occur. Penicillin, gold, non-steroidal anti-inflammatory, sulfonamide are examples of drugs that have been related to develop a drug-induced lichenoid reaction. Predominantly, it is unilateral and present with an ulcerative reaction pattern. Correct diagnosis is easier to establish when the patient develops reaction after starting a new medication. may not develop for several months after a new medication is started. It may also take several weeks before the reaction. Now what is the management of a drug-induced lichenoid reaction? It is not usually conjuncted with severe life-threatening reactions such as toxic epidermal necrolysis, discontinuity of the drug, and symptomatic treatment with topical steroid are often sufficient. The patient should be educated about the responsible medication causing this condition to prevent further reaction in the future. So every patient should know what type of medication causing this delay hypersensitivity reaction, so to be away from them from their use in the future. The major cause of a lichenoid reaction of a graft versus host disease is allogenic hematopoietic cell implantation. Oral lichenoid reaction as part of graft versus host disease may be seen both in acute and chronic form. In case of transplantation of a hematopoietic cell, such as bone marrow, clinically are indistinguishable from oral lichen planus, that is reticulum erythematous ulceration, but lichenoid reaction associated with this type of condition are typically associated with a more widespread involvement of the oral cavity. It is not possible to distinguish between oral lichen planus and oral graft. The same treatment strategy for oral lichen planus may be used for chronic oral graft versus host disease, that is topical steroid preparation such as flucosinide and clobetasol gel. Opportunistic infections such as candidal albicans always may be considered in such patient with immune suppressive medication or state. The development of secondary malignancy in this group of patients recognized as a potentially serious complication of this condition. Patients with a history of oral graft versus host disease should be always examined, followed up for oral malignancy. Now we will talk about the lupus erythematosus. Both natural and adaptive part of immune system are participating with later involvement of both beta and B cell, B and T lymphocyte cell. Moreover, environmental factors are important such as sun exposure, medication, chemical substance, hormone, which all have been reported to aggravate this disease. A genetic predisposition is supported by an elevated risk for sibling to develop lupus erythematosus. More than 80 different medications have been associated with the onset of systemic lupus, including hydrazine, methyldopa, chlorpromazine, isoniazid, guanidine, and procainamide. Systemic lupus erythematosus predominantly affect women of reproductive age, and the prevalence decreases during the menopause. This predominance has lent support to an involving the hormone in the pathogenesis of lupus erythematosus, as well as the fact that the disease can be precipitated by hormonal therapy. So there is a relation between lupus erythematosus and the hormone therapy. There are large variation in distribution of this disease between different ethnic groups. The oral lesion observed in systemic lupus and discoid lupus are similar in their characteristic clinically and histopathologically. The typical clinical lesion comprise a white striae with a radiation orientation, and these may sharply terminate toward the center of the lesion, which has a more erythematous appearance. The most affected sites are the gingiva, buccal mucosa, tongue, palate. The lesion in the palate can be dominated by erythematous lesion. These lesions may form a butterfly-like rash or laboratory finding for lupus erythematosus, including anti-nuclear antibody, anti-D, anti-TMS antibody, direct immunohistochemistry to reveal granular deposition of IgM, IgG, IgA, and C3, lupus band test. Anti-D and anti-Smith antibody are the most pathognomic for the systemic lupus erythematosus. Anti-nuclear antibody can be seen in other patients such as rheumatoid arthritis patient, Sjogren syndrome, so it is not specific. Diagnosis of oral mucosal lesion seen in conjunction with different type of lupus are clinically and histopathologically indistinguishable. Liquefaction degeneration may also present, which may result in diagnosis problem in relation to oral lichen planus. So it can be distinguished histologically from oral lichen planus because now we will talk about the other type of red and white lesion, which is the allergic reaction. Lichenoid contact reaction due to delay hypersensitivity reaction to a constituent derived from dental material. The majority of patients are patch test positive to mercury, which tend to support the lichenoid contact reaction belong to an allergic reaction. Although mercury is usually considered the primary etiological factor, other amalgam constituents may management. The oral lesion may respond to systemic treatment used for the disease. When symptomatic intraoral lesions are present, topical steroids such should be considered. The treatment may be begun with the application 2 to 3 times a day, followed by a tapering during the next 6 to 9 weeks. Oral mucosal lesions often mirror the disease activity. They may regress spontaneously but can also persist for months or even years. The overall object is to clinical finding. Oral lichenoid contact reaction are considered to be type of delayed hypersensitivity reaction to a constituent derived from dental material, mostly amalgam filling material. Clinically display the same reaction pattern as in oral lichen planus, reticular, papular plaque, erythematous, and ulcer. The most common appearance, clinical difference between them is the existence of the lesion. The majority are confined to the site that regularly contact with dental material such as buccal mucosa, lateral border of the tongue. The majority of this type of lesion and removing of the cause. Diagnosis. The diagnosis is primarily based on the topical relationship to dental material. The patch test is of minor clinical significance as the substance in patient with contact lesion will test negative to relevant the test compound. Although the lesion will resolve following replacement of another dental material, histopathology will not be of any assistance in discrimination between oral lichen planus and lichenoid contact reaction because it has the same, both of them has the same characteristic. Now, what is the management? Replacement of dental material in direct contact with the tissue will result in a cure or considerable improvement in at least 90% of cases. Most lesions should be expected to heal within 1 to 2 months. There is no need for replacement of restorative material that are not in contact or in direct contact with the oral mucosa. Healing does not seem to depend. You can see here the lesion associated with the use of Swedish snuff, and here smokeless tobacco with the pronounced Now we will talk about the frictional hyperkeratosis. Oral frictional hyperkeratosis is a typically clinical characteristic by a white lesion without any red element. So it is a purely white lesion. The lesion is observed in area of oral mucosa subjected to increased friction, for example, food intake. Observed in area subjected to increased abrasion, stimulate the epithelium to respond with increased production of keratin. The reaction can be regarded as a physiological response to a minor trauma. So there is a continuous chronic trauma. The oral mucosa will respond to this trauma by production of keratin. The prevalence has been reported to be in range of 2 to 7%. Smoking, alcohol consumption has been reported to be as a predisposing factor. Frictional keratosis is often seen in edentulous area of the alveolar ridge, asymptomatic but may cause anxiety for the patient because most of patients suspect So this picture shows the frictional keratosis of edentulous alveolar ridge. The diagnosis mainly depends on the clinical feature. It does not carry any symptom. If the diagnosis is doubtful, biopsy is mandatory to exclude malignancy. The ultimate way to differentiate between frictional keratosis leukoplakia is to reduce or eliminate the predisposing factor and await remedy. Wait and see. Remove the factor, remove the causative factor, and wait to see the effect. The management of a patient with frictional keratosis, there is no surgery intervention is indicated, no malignant nature of the lesion, attempt to reduce. Now we will talk about the other red and white lesion in the oral cavity, including benign migratory glossitis, geographical tongue, leukodema, white spongy nevus, and hairy tongue. We will start with the geographical tongue. It is an annular region affecting the dorsum and the margin of the tongue. Typical clinical manifestation comprises a white, yellow, or a gray, slightly peripheral zone. One of the most prevalent oral mucosal lesion in the oral cavity, hereditary, has been reported, suggesting involvement genetic factor in the etiology. The most frequently reported prevalence is in the range between 1% to 2.5%. There is a variation considerable between different investigation, which may be reflect geographical differences, patient selection, procedure, and diagnostic criteria. The gender distribution is equal, circumferentially migrating, and leave an erythematous area behind, reflecting atrophy of the filiform papillae. So it leukodema. The etiology of leukodema is not clear. Leukodema is a white and veil-like alteration of the oral mucosa, merely consider a normal variation. So it is a normal variation. The condition is often bilaterally in the buccal mucosa and sometimes at the border of the tongue. It is less clinically evident after stretching of the mucosa, but appear after this manipulation is discontinued. It is more pronounced in the mucosal fold. The condition is asymptomatic and has no malignant potential. The clinical features of leukodema are quite different from oral keratosis, such as leukoplakia, as the demarcation is diffuse and genital stretching results in a temporary disappearance. Treatment: there is no demand for treatment as the condition is non-symptomatic and has no complication. This is how the leukodema. Now, white spongy nevus. White spongy nevus initiated following a mutation in gene that are coding for the epithelial keratin in type K4 and K13. It has been listed as an autosomal dominant disorder. It is a rare disorder by the National Institute of Health by a prevalence of below 1 in 200,000. The clinical appearance usually commences during adolescence. Gender distribution is equal. The typical clinical appearance is a white lesion with an elevated and irregular surface comprising fissure or plaque formation. The most affected sites are the buccal mucosa, but the lesion may be seen in other areas of oral cavity covered by hyperkeratinized or non-keratinized epithelium. The disorder may also involve other extraoral sites, esophagus, and anogenital mucosa. Although the lesion does not entail any symptom, the diagnosis: a differential diagnosis problem for other oral disc keratosis such as oral leukoplakia and plaque-like candidiasis. The hallmark microscopic feature of this disorder is pronounced. Management: white spongy nevus does not entail any symptom and no treatment is therefore required. Systemic antibiotics have been used in an attempt to resolve the disorder but without any benefit. When the positive effect is obtained, the recurrence condition. Now we will talk about the hairy tongue. The etiology of hairy tongue is unknown. In most cases, a number of predisposing factors have been related to this condition or this disorder. First of all, neglected oral hygiene, a shift in oral microflora, antibiotic and immunosuppressive drugs, oral candidiasis, excessive alcohol consumption, oral inactivity, therapeutic radiation, and associated smoking habit. Both of neglected oral hygiene and oral inactivity can be seen in hospitalized patients. The reported prevalence varies between different geographical areas. Diagnostic criteria: clinically, hairy tongue is characterized by impaired desquamation of the filiform papillae, which lead to the hairy-like appearance of the tongue. The elongated papillae may reach to in excess of 3 mm to be classified as a hairy, although length of more than 15 mm have been reported in patients with hairy tongue. The lesion is commonly found in posterior 1/3 of the tongue, but may involve the entire dorsum of the tongue. Hairy tongue may adopt color from white to black depending on the food constituent and the composition of the oral microflora. Patients experience both physical discomfort and aesthetic embarrassment related to the length of the filiform papillae. What is the management of patients with hairy tongue? The treatment of hairy tongue is focused on reduction or elimination of the predisposing factor and removing the elongated papillae. The patient should be instructed to how to use a device developed to scrub the tongue using abrasive food may prevent the recurrence of this condition. Attempts have been made with retinine acid, vitamin A, but this treatment has not reached a wide acceptance by the doctors. Patients should be informed about the benign and the non-contagious